A 30-year-old right-hand dominant female presents with swelling, pain, and deformity in the wrist. She reports that while mountain biking, she fell on an outstretched hand. She reports no previous history of injury to her right hand or wrist joint. You examine the patient's circulation of the rings, the fingers and the hand is normal. Capillary fill is optimal and is less than 2 seconds. A sensory and motor examination of the other median distribution is done. A dissociation between the distal radius and the proximal row is noted, and a palmar mass is at the base of the hand is palpable. You proceed with the X-ray of the patient. Lateral radiograph demonstrates dorsal displacement of the capitate. The proximal pole of the scaphoid is rotated dorsally as the scaphoid is palmar flexed. The AP radiograph verifies distal carpal row overlapping to the proximal carpal row. The scapholunate ligament interval is more than 2 mm. A perilunate and lunate dislocation often results from a fall on outstretched hand. Carpal dislocation results from dorsiflexion. The proximal row of the carpal are held tightly in position by the group of ligaments between the radius and the carpus. Due to this relationship, perilunate dislocations are more common than lunate dislocations. Perilunate dislocations are characterized by the dorsal usual displacement of the capitate, which comes to rest in the posterior aspect of the lunate, causing the lunate to tilt volarly. The lunate maintains articulation with the distal radius in stage 3. With lunate dislocation, that is stage 4, the capitate maintains its normal alignment with the distal radius, whereas the lunate is dislocated volarly. In most severe injuries, the lunate may be dislocated into the carpal tunnel. Indeed, we have seen lunate being dislocated into the forearm as well. The vast majority of perilunate dislocations are dorsal, and many have associated fractures. These include fracture of the scaphoid waist, radial styloid, capitate, and ulnar styloid. When talking about the stages of perilunate instability, stage 1 involves a break or a tear in scapholunate ligament complex. Stage 2 interrupts the lunocapitate relationship with the force of injury moving through the space of Poirier. Stage 3 is a perilunate instability. The lunotriquetral connection is lost, and the carpus separates from the lunate. Stage 4, the lunate dislocates from its fossa, often to the carpal tunnel, and the capitate aligns back with the radius. Most acute perilunate dislocation requires surgical intervention. Close reduction is possible, but it is unlikely that reduction will be maintained with immobilization alone. A ligamentous injury alone can be treated with the dorsal approach only. However, the status of the median nerve may require a combination of dorsal and the palmar approach. For the dorsal approach, an incision is made in line with listed tubercle. An interval between the third and fourth compartment is identified and is made by dividing the distal portion of extensor retinaculum and septum between the two compartments. The tendons are retracted and the capsulotomy is performed unless it is torn from the injury. The dorsal attachment to the carpus are released, and the scaphoid, lunate, capitate, and the lunotriquetral attached articulation are visualized. Care should be taken to preserve the blood supply of the proximal pole of the scaphoid. A scaphoid and lunate are manipulated into anatomical position, and a 0.062 inch K-wire is placed in the dorsal palmar direction into the lunate, and other parallel K-wire is placed in the proximal pole of the scaphoid. The K-wires are placed close to the palmar cortex, as they can be used as lever to restore the scapholunate angle. The scaphoid is manipulated to reduce palmar flexion, and the lunate is manipulated to reduce dorsiflexion. 2.05 inch K-wires are then percutaneously drilled from the radial side of the carpus through the proximal pole and the mid pole of the scaphoid into the lunate. A third wire is placed in the proximal from pole of the scaphoid and into the capitate. If the scapholunate interosseous ligament is torn off the bone, additional K-wires may be placed. A suture is also placed to repair the torn ligament to the bone surface. The K-wire is restored with an anatomical relationship. The wrist capsule is closed and extensor retinaculum is sutured. At this point, some surgeons perform a reverse plate capsulodesis prior to the closure, and the skin is closed. Post-op, the spica cast is applied at 14 days, and at 8 weeks is changed to a Munster type of a cast. Pins may be removed at 8 to 12 weeks. Finger movements are encouraged through the immobilization period. At 8 weeks, we place a short arm cast for 6 weeks, and we begin active mobilization of the wrist at 3 to 4 months' time. Indeed, the rate of post-traumatic arthritis has been reported to be as high as 56% even in surgically treated perilunate dislocations. Other complications such as spin tract infection or carpal tunnel syndrome can often be prevented.